Okay, so question 1, 20-year-old female is evaluated in emergency room for a generalized tonic-clonic seizure. Her friend informed that she took 3,4-methyl-endoxy methamphetamine ecstasy ပေါ့လေဗမာပြည်မှာတော့ယာဘာအနေနဲ့ထွက်တယ်နဲ့တွေ့ ecstasy several years ago. On exam, temperature 37.8, blood pressure 90/50 millimeter mercury, respiratory rate 24 per minute. Neuro exam unresponsive to painful stimuli, but no localizing neurological finding. Remainder of the physical exam is unremarkable. Laboratory data showed sodium of 118 milliequivalent per liter, glucose 98 milligram per deciliter, potassium 4.1, chloride 90, bicarbonate 19, BUN 18, and serum creatinine 0.9. So the question is the single best response. Which of the following is the most appropriate next step in this patient's management? A, 3% hypertonic saline infusion. Number 2, water restriction. Number 3, intravenous conivectin. Number 4, IV desmopressin. Number 5, IV furosemide. All right, can we poll? Okay. All right, so let's move on to the second question. Question number 2. A 63-year-old female is known with type 2 diabetes and hypertension. She normally takes glipizide and lisinopril/hydrochlorothiazide 20/12.5 for those conditions. She came down with COVID-19 pneumonia a week ago and had fever ranging from 100 to 101 degrees Fahrenheit during the past 3-4 days. She had poor PO intake and became extremely weak. Her saturation of oxygen remains in 85 to 89%. She is being treated at home with a visiting physician who drew labs yesterday. Today, labs came back showing sodium of 138, potassium 6.8, chloride 102, bicarbonate 19, BUN 74 milligram per deciliter, and creatinine 1.9. No hemolysis was reported with the blood sample. Your next action include choose all applicable. So it could be multiple answers might be correct. Number 1, get an urgent ECG. Number 2, give oral sodium polystyrene sulfonate. The brand name is Kexalate, 30 gram. Number 3, call ambulance and sending to a hospital that can perform dialysis. Number 4, give 50 gram of IV push sodium bicarbonate. Number 5, give 4 milligram of oral albuterol. Number 6, give 10 cc of 10% intravenous calcium gluconate. Number 7, give 50 cc of 50% dextro IV with 10 units of regular insulin IV. Mohin Joy, I apologize. This is not single choice. So I don't all နဲ့ဖြေလို့ရပါမလားတော့မသိဘူးခုမှ
ဟုတ်ကျွန်တော်multiple choice လုပ်ထားပါတယ်ဆရာ
Okay ဟုတ်ပြီ Thank you
ဆရာဆရာမတို့ဖြေလို့ရပါတယ်တစ်ခုတည်းပို့ပြီးဖြေလို့ရပါတယ်ကျွန်တော်ဒီတောင်းပန်စရာလေးတစ်ခုရှိပါတယ်ဒီထဲမှာကျွန်တော်choice 7ဆိုပြီးတော့အဲ့ဒါကြီးကတစ်ခုအပိုပါနေကျွန်တော်အဲ့ဒါကိုဖြတ်ဖို့မေ့သွားလို့ပါchoice 7ကိုဆရာဆရာမတို့ဖြေကြမလို့ပါဘူးဆရာရဲ့ကျွန်တော်တို့ဒီဘယ်အောင်ရွေးရမလဲဆိုတော့ခုနကကျွန်တဲ့နေရာတွေမှာကျွန်တော်ထည့်ထားပါတယ်ခင်ဗျဟုတ်ကဲ့ပါတစ်ခုတည်းပို့ပြီးရွေးလို့ရပါတယ်ဗျ anonymous လေးလုပ်ထားပါတယ်ကျေးဇူးပါဆရာဆရာမတို့
Okay အဲ့ဒါဆိုရင် let's start with today's lecture ဟိုမနေ့ကတော့ဆရာ very briefly introduction လေးပြောပြပါပြီမနေ့ကတက်တဲ့လူတွေပဲလားတော့မသိဘူးဒါပေမဲ့နည်းနည်းလေးပြန်ပြီးတော့ quickly ပြောလိုက်ပါမယ်ဆရာဟိုဒီ COVID နဲ့ပတ်သက်ပြီးတော့ nephrology နဲ့ပတ်သက်ပြီး two topics ပေါ့လေ most relevant ဟို COVID take care လုပ်နေတဲ့ဒီမြန်မာပြည် front line ကဆရာဝန်တွေအတွက်ပြောပြပါဆိုတော့စဉ်းစားကြည့်လိုက်တော့တကယ်တမ်း COVID က pure nephrology issue မဟုတ်ဘူးလေ it's more of like infectious disease or pulmonary issue. Yes, when the COVID patients become very sick, you can develop electrolyte abnormalities and acute kidney injury or acute renal failure. So ဆရာစဉ်းစားလိုက်တာ COVID တိုက်ရိုက်နဲ့ပတ်သက်ပြီးမှပြောမယ်ဆိုတော့15 minutes စာလည်းပြောပြီးပို့လို့မရှိဘူးဒါပေမဲ့ to make the best use of the time ပေါ့နော် acute kidney injury ကြောင်း A1 မှာပြောလိုက်မယ် acute ပြီးတဲ့ခါမှာတော့ most likely relevant clinical condition and any type of acute illness for COVID မှာရမဟုတ် any type of pneumonia any type of acute illness ကတော့ common electrolyte disorders and volume overload states and also proper use of diuretics ပေါ့လေဟိုတတ်တန်ပြီးမှ pharmacology မှာသင်လာပြီးတဲ့နောက်ဟို basic concept လေးတွေမိတ်သွားတတ်တယ် but those have true real world usefulness and relevance so I thought I will quickly go over it hope you know အဲ့တော့ဟိုမနေ့ကပြောသလိုပဲဆရာက1987ကစေချောင်းပြီးတယ်88မှာ house surgeon ပြီးတယ်တစ်နှစ်လောက်ရန်ကုန်မှာ GP လုပ်ပြီးတော့89ကမြန်မာပြည်ထွက်လာတယ်အင်္ဂလန်ကို4နှစ်လောက်ရင်သွားပြီးလုပ်လိုက်တယ် MRCP ပြီးတော့93လောက်မှာ US ကိုကူလာပြီးတော့ residency နဲ့ fellowship ပြန်စပြီးတော့2001မှာ nephrologist ဖြစ်ပြီးတော့အခု this is my 20th year practicing as a nephrologist ပေါ့ okay so when I talk about မနေ့ကပြောသလိုပဲ when I talk about some of the lectures what I noticed ကဒီခုနောက်ပိုင်းမှာဆိုလို့ရှိရင်ကျောင်းသားတွေအတွက်ကဒီ lecture material ဆိုတာသိမခက်တော့ဘူးလို့ထင်တယ် internet ပေါ်မှာ widely available WebMD တို့ up to date တို့ even textbook တွေin the you know e-format တွေအများကြီးရှိနေတယ်အဲ့တော့ဖတ်စရာတော့ material တော့မခက်ဘူး widely available ဒါပေမဲ့ဘာသိဖို့လိုလဲဆိုတော့ the real concept ပေါ့နော် otherwise ကတော့ဘာလို့မှလဲကိုယ့်ကိုထားဖတ်လဲရတာပဲအဲ့တော့ hopefully I can give you some physiologic background and related to clinical conditions so that you can apply those in your day-to-day life. So for that, we need to go back a little bit to some of the physiological concept that we learned in second MB. Just to quickly refresh, you know, our body at the weight 60% of the body weight is made of water. So again, a lot of these diagrams are Western, based on Western population. So we assume that somebody is, you know, typical average adult Westerner is about 70 kilogram, which is about 150 pounds. So that's why this is calculated, assuming that this individual has 70 kilogram body weight. So 60% of the body weight, so about 42 liter is the total body water. Out of that, 60% is in intracellular, 40% is extracellular. Again, out of that 40%, only about 1/4 of that 40% is inside the blood vessel, intravascular, and the rest are interstitial. Of course, blood vessel and interstitial space capillary endothelium divideလုပ်ထားတယ် and between intracellular and extracellular cell membrane divideလုပ်ထားတယ် and even out of that 4 liter plasma volume, the real volume that determine the neurohormonal response ဟာ body ကိုမှာ dehydration ဖြစ်နေလား volume depleted ဖြစ်နေလား volume overload ဖြစ်နေလားဆိုတာကို sense လုပ်တယ်အရေးကြီးတဲ့ volume that volume is called effective blood volume เนาะတကယ်အရေးကြီးတဲ့ volume that measures only about 0.7 liter and that volume is sensed by the stretch receptors along the vascular bed အဲ့တော့မနေ့ကပြောသလိုပဲဒီ human တမကောက် every living organism for the survival သူတို့အသက်ရှင်ဖို့အတွက်ဆိုလို့ရှိရင် that evolutionary step the built-in feedback mechanism တွေရှိတဲ့ဟာက to maintain and restore the effective circulatory volume is the most important thing ဟလား hypotension ဖြစ်မယ် shock ဖြစ်မယ် quickly correct မလုပ်နိုင်ဘူးဆိုလို့ရှိရင် cerebral hypoperfusion ဖြစ်ပြီးသတိမေ့သွားမယ် cardiac hypoperfusion ရမယ် ischemia ရမယ်အဲ့တော့အဲ့ဒီလိုမျိုးဟာတွေကို offset လုပ်ဖို့အတွက် body မှာ built-in mechanism ရှိတယ်အဲ့ဒီ built-in mechanism ဆိုလို့ရှိရင်သူ့မှာ two arms ရှိရမယ် one arm က sensory arm to sense the volume status and then the other arm is effector arm which is the response mechanism. Now to again one basic concept မနေ့ကပြောလို့မမေ့ဘူးဟာ the body fluid တွေမှာ solution the water is permeable across all the cell membrane. Water is very permeable across either endothelial membrane or cell membrane, but the movement of the water across those cell membranes are barely determined locale solution. The respective component, osmolality, determined locale, osmolality high ဖြစ်နေတဲ့ solution အဲ့ဒီ compartment နဲ့ကို hypoosmolar တခြား compartment ကနေ water move ဖြစ်မယ်အဲ့တော့ if you want to shift water you need to have a control of the osmolality of that individual compartment and likewise 80 to 90% of our body fluid osmolality is contributed by sodium molecule. So this is just a breakdown of main electrolytes that confer the osmolality of different body compartments, may it be either intravascular, interstitial, or intracellular. Majority of them, is provided by the sodium molecule. Of course, you have to have opposing electrolyte that goes to cations to offset the anion to maintain the electrical neutrality. So this is the little quick overview of volume repletion reaction in the human body. You can have reduction in effective circulatory volume. Effective circulatory volumes for to get the stretch receptor, the vasoreceptor, sense လုပ်တဲ့ဟာအဲ့ဒီဟိုဥမာဆိုရင်ဘူစီပေါင်းကြီးကဖောင်းမနေဘဲနဲ့ပိန်နေတယ်လို့မျိုးပဲပေါ့အဲ့ဒီဟာတွေကို sense လုပ်တဲ့ mechanoreceptor တွေကဘယ်မှာရှိလဲဆိုလို့ရှိရင် left atrium မှာရှိတယ် major thoracic vein တွေမှာရှိတယ် carotid sinus, aortic arch, juxtaglomerular apparatus. And effective circulatory volume or effective blood volume are what factors determine the effective blood volume swing. The two main factors are cardiac output and peripheral vascular resistance. So peripheral vascular resistance vasodilateဖြစ်တယ်ဟာလား septic shock ဖြစ်လို့ blood vessel area flabby ဖြစ်နေတယ်ဆိုလို့ရှိရင် even giving with the same blood volume because of the capacity has disproportionately increased, the body will see as reduced fullness of arterial circulation. Likewise, when you have reduced cardiac output because of the blood loss, volume depletion, you will see the body will sense the effective circulatory volume is reduced. So then what happens is these mechanoreceptors are stimulated, they discharge neurohormonal responses leading to neurohormonal cascade. I will show it in the next slide what neurohormonal cascade entails, but just as a summary, because of the initiation of that neurohormonal cascade, the responses are increasing peripheral vascular resistance, which is by virtue of vasoconstriction, or increasing cardiac output, either through renal sodium and water retention or direct stimulation for the cardiac activity, all of those resulting in restoration of effective blood volume. So this is the quick summary of what is the neurohormonal cascade entails. Neurohormonal cascade လို့ပြောလိုက်လို့ရှိရင်ဘာပါလဲဆိုလို့ရှိရင် the yellow arrows indicate the positive feedback and green arrows indicate the negative or inhibitory. There has to be a limiting mechanism. Once we have restored the volume, we don't want to overfill the volume. So once the volume has restored enough, then we have to cut off the response and we have to have negative or inhibitory mechanism to stop those circles. So when you are faced with volume depletion, I will not go into detail. This neurohormonal cascade is kicked on, that will lead to increase in angiotensin II production from juxtaglomerular cells of the glomerulus because of the sympathetic system. This is the stress reaction. Sympathetic system is stimulated. Antidiuretic hormone will be stimulated. And nowadays, we also have come to understand that the capillary endothelium produce hormones or substances like endothelium. All of those were stimulated or increased. Those led to subsequent mechanism, for example, like angiotensin. As you know, angiotensin II stimulate the angiotensin aldosterone system, which lead to increased production of aldosterone, which act by reclaiming the sodium at the distal convoluted tubule. So once the sodium is reabsorbed, water follows the sodium and the end result is volume is restored. But angiotensin II has other additional actions, such as like it can stimulate the central nervous system directly, leading to thirst sensation, again, which will make you drink, leading to volume repletion, restoration. Angiotensin II is a vasoconstrictor, which will lead to increased peripheral vascular resistance. Stimulation of catecholamines will lead to vasoconstriction. They can also increase the sodium reabsorption at the kidney. Endothelium is a vasoconstrictor. Antidiuretic hormone, as the name implies, it leads to antidiuresis. So there will be less water excretion. Urine is more concentrated, but the end result is body is trying to reclaim the water and restore it as much as it can. So the end result is volume repletion or volume restoration. But when enough volume restoration takes place, substances like atrial nucleopeptide and PGE2 are released from atrium, which will inhibit those circuits that will atrial nucleopeptide will inhibit aldosterone synthesis, and we'll have all the negative feedback. So by this way, body's effective circulatory volume is restored and patient doesn't end up being in a shock state. So this is just a refresher of how body respond to either volume depletion or volume overload status. And again, this is a little cartoon that I have used from yesterday's lecture. Some of you may have attended yesterday's lecture. The kidneys are a very important organ of volume control. And also to understand the mechanism of diuretics, you need to have some recollection of how the tubular epithelial cells work. So this is the amplification of the one tubular epithelial cell. The tubular epithelial cell, they have a lot of these cell surface pumps, both at the luminal surface or the membranous surface or at the basement membrane level. And these are energy consuming pumps. Because they consume energy, they can reabsorb or excrete the electrolyte against the concentration gradient. They don't have to rely on osmolality. So that's the peculiarity. And likewise, because of energy consumption, these renal tubular epithelial cells consume a lot of oxygen, and that's why they are sensitive to ischemia. So going back to the basics, loop diuretics, as the name implies, furosemide, bumetanide, torsemide, they all act in the loop of Henle. All the diuretics, the way how they act it is, they have to, they are protein bound, so they are not filtered. They don't get here from filtering through basement membrane. They have to be secreted through the tubular cells into the lumen. And then on the luminal surface right here, they block this pump. Loop diuretic, they block sodium potassium 2-chloride pump. So because of that, sodium is not reabsorbed. So sodium is sitting in the tubular lumen. And like I have told you earlier, when there is sodium, water will follow through. So that's how diuresis takes place. So sodium is sitting in the tubular lumen instead of being reabsorbed. And because of that, water sit along with the sodium and you achieve diuresis. This is just a little bit of recollection of the renal anatomy. This is the glomerular capillary tuft, Bowman capsule, proximal convoluted tubule, loop of Henle, descending link, ascending link, distal convoluted tubule, and collecting duct. Loop diuretics, they act on the loop of Henle. Thiazide class of diuretics, they act on the distal convoluted tubule, and aldosterone antagonists, they act on the collecting duct. On a day-to-day practice, loop diuretics are way much stronger these. But there is the reason I'm telling about this anatomy is there is a applicable clinical concept how we can combine the diuretics and trying to amplify the action. So that's why I want to show where the different diuretics act. So this is just a recollection of where the diuretics act, but beware, all the diuretics except aldosterone antagonists, they have to be secreted through the renal tubular epithelial cell, and they have to sit on the cell surface, blocking the respective pumps. Carbonic anhydrase inhibitors, very mild, they act on the proximal convoluted tubule level. They block the sodium potassium exchange pump. Loop diuretics, they act and they block the sodium potassium 2-chloride pump, which is located at the thick ascending link or loop of Henle. Thiazide diuretics, they act on the distal convoluted tubule. Aldosterone antagonists, they act on the collecting duct. Amiloride is peculiar. It directly go and block the sodium channel and prevent it from sodium being reabsorbed at the collecting that level. Diuretic property of amiloride itself and spironolactone are relatively very mild. Of course, if you compare diuretics property, loop diuretics will be strongest and the other will be weaker. Thiazide will be a little stronger compared to spironolactone and amiloride. So I went over a little bit about during the diagram, but let me go through by just reading out loud. So the diuretics, they act on the cell surface, transepithelial. They act by blocking the sodium reabsorption. So they have to be there to be able to exert their property. All diuretics except spironolactone has to be secreted because they are highly protein bound and they are not filtered. So why I'm emphasizing is if you have reduced kidney function, when you have reduced GFR, the amount of diuretics secreted become less as well. So 20 milligram of furosemide in somebody who has normal renal function will not cut it in somebody who has creatinine of 3 and stage 4 CKD. They simply have to be giving higher dose so that higher proportion is secreted and be available. Another thing is that diuretics, they have a mechanism called a threshold dose to elicit. So, or low dose they have to have a threshold dose. The good thing is that in normal people with normal renal function, the threshold dose is pretty small. And then there is also a ceiling dose. After certain dosage, the response doesn't increase. So the reason that concept is useful is that, for example, like soလူတယောက်ကို diuretic ပေးမယ်ဒီလူကအဒီမှရှိလို့ diuretic ပေးမယ်သူ့ကိုတစ်နေ့ကို40 mg ပေးမယ်ဆိုလို့ရှိရင်10 mg စီခွဲပြီးတော့၄ခါလောက်သွားပေးနေလို့ useless ပဲ one single dose 40 mg ပေးတာပို့အကျိုးရှိလိမ့်မယ်ဘာဖြစ်လို့လဲဆိုတော့ if you give 10 mg each time it would not reach the threshold dose so it would not kick in the response but 10 mg ဟလာ၄ခါပေးမယ်အစား40 mg one dose ပေးရင် it will reach the threshold dose so that's one of the concepts. And the other thing is that there is a physiologic concept called compensatory sodium reabsorption, the distal nephron segments, and stimulation of neurohormonal mechanism once diuretics are initiated. So what happened diuretics စပေးလိုက်လို့3-5ရက်ကြာပြီဆိုလို့ရှိရင် body မှာ compensatory response ရလာတယ်ဟုတ်လား loop diuretic ဆိုပါတော့ loop diuretic ကဒီမှာ loop level မှာ sodium reabsorb လုပ်တာကို inhibit လုပ်တယ်အဲ့ဒီကြောင့်မလို့ sodium တွေက more distal part ကို deliver လုပ်ခါရမယ်ဒီ more distal part distal convoluted tubule collecting that ကိုရောက်လာတဲ့ဟို ultrafiltrate တွေမှာငကိုတဲ့ပို့ပြီး sodium တွေများနေတယ်အဲ့တော့ဘာဖြစ်လာမလဲဆိုတော့ဒီ level မှာရှိတဲ့ pump တွေက hypertrophy ဖြစ်လာမယ်ဒီဟလာ distal convoluted tubule မှာရှိတဲ့ sodium chloride pump sodium hydrogen pump they start to get hypertrophy and they start to reabsorb more sodium compared to a normal situation. So ဒါကြောင့်မလို့ after diuretic စပေးပြီးတော့4-5ရက်လောက်နေလို့ရှိရင် dose မပြောင်းလို့ရှိရင် compared to the first day you reach a steady state and the diuresis response become very minimal. So this is just the slide that to show the physiological response or how the diuretics work. Very old slide, you know, from the 80s. So what it shows is that the dose of furosemide giving on the x-axis, on the y-axis is the sodium excretion. Diuretics affect also sodium excretion. At very low dosages, there is no sodium excretion take place. So that's why this is where the threshold dose. Only when furosemide gets to that peculiar dose, then sodium excretion start to pick up. Even then, the slope is different between a normal person, which is represented by a red line, versus congestive heart failure. The slope is much more blunted in people with congestive heart failure. And this is another very 40-50 years old physiological response of the diuretics. When someone is giving diuretics and when you go and measure the sodium excretion in the urine per day, in the first 3-4 days, yes, there will be net sodium balance. There will be more sodium going out compared to what is going in. But after a few days, the effect become very much less and you reach to a steady state because of that compensatory mechanism kicking in at the distal nephron segments. So why do we have diuretic resistance? Sometimes you may have come across this patient has edema but not responding to diuretics. Couple of possibility. Number one is not achieving the effective threshold dose for natriuresis, like I explained to you earlier. Instead of giving tiny little doses, 4 times a day, we should give one single dose. Luckily, in people with normal renal function, you do not need to have much higher dose to achieve the threshold for natriuresis. 10 milligram can initiate the natriuresis response. And by the time when you have given 40 milligram of IV Lasix, we have blocked almost all the available, sodium chloride transporter pumps. On the other hand, there are exceptions. When you have circumstances such as like congestive heart failure, nephrotic syndrome, chronic renal failure, those conditions are associated with reduced secretion of diuretics across the transepithelial cells. So consequently, there will be less diuretics available at a given regular dosage. So it's not surprising you have to use much higher dosage. So this maximal dose, ceiling dose of 40 milligram is achieved in a normal population, but in disease stage, sometimes you may have to use up to 160 milligram of furosemide IV to achieve the ceiling dose. And another thing is that, there are a few other conditions. Another thing is that if you are giving diuretics in an oral method, in case of edema, there seem to be some mucosal edema of the gut or intestine. So to make the long story short, there is less bioavailability. If you give oral route, you have to give much higher dosage, or you should start with IV route. And if you must use oral preparation, bumetanide, which is Bumex, and torsemide, which is Demodex, have better absorption and better bioavailability compared to the furosemide. Another reason why you face with diuretic resistance is that patient is not restricting the salt intake. Regardless of how high a dose, how correct a diuretic regime you are giving, if the patient doesn't stop or cut down the sodium intake, it will not be effective, because all depend on whether we can have net sodium loss in the urine. So if the patient doesn't restrict sodium intake, that may be the reason diuretics are not as effective as it can be. Lack of bed rest may play a small role, theoretically, not a big role. It's just simply because when you are in a lying position, there is, slightly increased blood flow to the kidney. Renal blood flow is better in a lying position compared to standing position, even in normal population. So there is some truth in the old wisdom that bed rest is indicated in every type of illness. That's not, the recommendation. Then we have some truth in the physiologic explanation. And the other thing is that failure to prevent compensatory sodium reabsorption in distal nephron segment. So to offset that, we have to use a concept called sequential nephron blockage. Remember, I told you that thiazide class of diuretics by itself, they are not a very strong diuretics, but if you use it in conjunction with loop diuretics, what's going to happen is that loop diuretics will be acting at the loop, and the consequence is that there is increased sodium delivery to the distal convoluted tubule and loop of Henle. But if you are concomitantly using thiazide class of diuretics, the compensatory sodium reabsorption will be prevented at here. So, you get bigger bang for the buck. Thiazide diuretics, loop diuretic at it doesn't have a very strong diuresis property, but if you use in conjunction with loop diuretics, it can significantly amplify the response of the loop diuretic. So this concept is called sequential nephron blockade. So you get a bigger bang for the buck. Another mechanism where you can amplify the diuretic response if you give diuretics by continuous IV infusion, because as you know, loop diuretics are relatively short-acting. They stay in the body maybe for about 6 to 8 hours. So if you give intermittent loop diuretics, this is the blue line, that is what you would find. You give bolus like every 6 to 8 hours, within the first half an hour or an hour, there is increased sodium excretion, but after about an hour, the sodium excretion start to decline. You give another dose, and with every dose, the peak sodium excretion become less and less. On the other hand, if we started off with a bolus dose to achieve the threshold and then maintain with the constant infusion, what we come to find is that the red line indicates the infusion, what we call as the area under the cuff, the net sodium excretion at any given time. So this is the area under the cuff of the red line. The area under the cuff of the blue line is like that. So what we come to find is that when it comes to at the end of the day, the area under the cuff is slightly better for the same amount of diuretics in total being used. The area under the cuff or the amount of sodium excretion is slightly higher by giving continuous. One thing to be aware is that using IV diuretics and drip is indicated for people who have responded to IV bolus, but we want to amplify it. It will not be useful for individuals who did not have any response to begin with when you started off IV bolus. So beware that, number one, there are some patients whose kidneys are completely shut down. They have no response to bolus dose of diuretics. In those patients, there is no point in switching to basic drip, furosemide drip. So drip is more for people who had responded to IV boluses, but we want to increase the response a little better. And the other thing is that even if you use the drip, beware that you have to give one bolus dose to begin with to achieve that initial threshold sodium excretion. So after that, you usually give furosemide about 20 milligram per hour, and we can go maximum up to 40 milligram per hour. So in practical time, day to day, you can mix, I don't know how furosemide Lasix ampule below lare, dimaro 40 milligram ampule lare, 100 milligram ampule lare, 100 milligram ampule, you put it in 500 cc of normal saline, and turn it into 10 milligram per 1 milligram per cc solution. We can run it at 20 cc per hour, and that will essentially give. The bottom line is that you would use the IV furosemide with the normal saline bag, either 100 cc or 500 cc bag. The rate is about 20 milligram per hour. Bumetanide, it's about 1 milligram per hour, and Torsemide is about 20 milligram per hour. So that's a little trick that you can use to improve the diuretic response. I will not go into detail of that, but that's just for your FYI information. Commonly used IV fluid preparation and their osmolarities and their sodium content or chloride content. Hypertonic saline, as the name implies, the osmolarity is about 1,000, whereas normal saline is, even though it is normal saline, technically it is not exactly normal osmolarity. It is mildly hyperosmolar. As you know, normal osmolarity is 275 to 285. So Ringer lactate is actually the more appropriate normal osmolarity solution. Normal saline is slightly higher osmolarity. Of course, hypertonic saline is much more higher. These are the contents of the how much sodium in each liter of these different solutions. A quick coverage on hyponatremia. So hyponatremia reflects disproportionate ratio of sodium and water. Hyponatremia solution, total body sodium 99% of the hyponatremia is due to impaired ratio of sodium to water. Either hemodilution ဖြစ်ပြီးတော့ရေကပုံများနေလို့ it reflects defective renal water excretion, and it doesn't mean that you will have volume depletion. Hyponatremia ရှိလို့ patient က volume depleted ဖြစ်နေလို့ပြောလို့မရဘူး hyponatremic patient can be isoosmolar, hyperosmolar, or hypoosmolar. So the kidneys are normally good in diluting the urine to adjust the sodium. If you become hyponatremic, the body normal response will be the kidney will start to make dilute urine so that ရေတွေများများထွက်မယ် in compared to sodium, and consequently blood sodium level will start to creep up. Hyponatremia, if it happens in acute setting, like within 24 hours, you can develop neurological symptoms because hyponatremia ရှိလို့ရှိရင် the blood or plasma osmolality will be reduced. As we have talked earlier, sodium is the main molecule that determines the osmolality, right? So when you have hyponatremia, consequently, the osmolality of the plasma compartment will be low. And then eventually, of course, because of that, water will shift from hypoosmolar compartment to normal osmolar compartment to the cellular volume expansion. And when that happens acutely, and when that happens in other part of the body, it doesn't matter. But when that happens in the brain cells, because brains sit in a very confined, rigid cranium, it doesn't have room to expand. So when you have rapid hyponatremia, there is increased intracranial pressure due to water crossing the blood-brain barrier. On the other hand, if hyponatremia has lasted for a couple of days, the brain has an adapted mechanism. It starts to excrete and it starts to lose brain solute from the brain cells. So the intracellular osmolality does not remain as high it is, so that water doesn't need to move into the brain cell. So the solutes from the brain cell, they can shed solutes in the brain cell. So the osmolality of the intracellular compartment in the brain become less, and consequently that prevent water entering it, and that prevent cerebral edema, which is all good and well. But the offsetting thing is that somebody who have long hyponatremia, because of that compensatory mechanism is taking place, if you go and correct that long-standing hyponatremia abruptly, the opposite will happen again, right? If you correct the serum sodium so quickly, the plasma component or the plasma compartment become normal osmolar, but the other compartments such as like interstitial or intracellular compartment remain hypoosmolar. So water will be moving from intracellular to extracellular. And if that happens in the brain cell, what happens is you develop myelinosis of the brain cell, particularly in the pontine area. It's called central pontine myelinosis. You can lead to sudden development of paraplegia. So hyponatremia, the duration is important. If hyponatremia takes place acutely, you can have neurological symptoms. But the good thing is, if we know for sure that this hyponatremia is acute, you can likewise correct it pretty quickly as well. You don't have to worry about brain demyelination. Whereas if hyponatremia has lasted for a long period, if it is chronic hyponatremia, you have to be careful in correcting it, because there may be demyelinosis and complication take place if you correct it too quickly. This is a quick algorithm to approach the hyponatremia. When you are faced with somebody with hyponatremia, you first look at the plasma osmolality. If plasma osmolality is high, it's usually because of factitious hyponatremia. There are osmotically active substances such as like poorly controlled diabetes. Mannitol is sitting in the blood and they are impairing with the osmolality measurement. If the osmolality is normal, it may be due to certain other conditions such as like hyperlipidemia, multiple myeloma, too much high protein. Whereas if the plasma osmolality is low, the next step is you look at the urine. How is the urine responding? In a normal person, if you have hypoosmolality, our kidneys should be making quite dilute urine, right? So if the kidney is making a lot of dilute urine, then the kidney is appropriately responding. The problem lies in somebody drinking a lot. So ရေရမ်းတောက်လို့ dilute urine ရမယ်ဒါပေမဲ့ if what he or she drinks exceed the body's diluting capacity လား psychiatric patient တွေမှာအဲ့တော့ urine ကတော့ဖြစ်တဲ့လို့ dilute ဖြစ်နေတယ်ဒါပေမဲ့အဲ့ဒီ dilute လုပ်နိုင်တဲ့ capacity ကိုတော့ကျော်သွားပြီဆိုရင်တော့ sodium level လာပြီး affect ဖြစ်တော့မှာပဲအဲ့တော့ primary polydipsia a lot of the time psychiatric patient or reset osmostat but if the urine is not maximally diluted then you look at the ECF volume. If the ECF volume is increased, things such as like heart failure, cirrhosis, nephrotic syndrome, which are leading to, compensatory water retention, causing hyponatremia. If the ECF volume is normal, that will fit with syndrome of inappropriate antidiuretic hormone secretion or hypothyroidism or hypoadrenalism, but ECF volume is reduced, then we go and look at the urine sodium. If the urine sodium is low, again, the kidney is responding appropriately to volume depletion. But the volume depletion is not from renal sodium loss, it must be from GI or other sources. On the other hand, if the ECF volume is reduced, and yet if the urine sodium is high, this is inappropriate, and that's because patient was taking diuretics or patient was having sodium wasting nephropathy or vomiting or hypoaldosteronism. So those are the quick algorithm of hyponatremia. So hyponatremia, relatively in clinical practice, hyponatremia is quite rare because as soon as hyponatremia sets in, it's a very strong stimulus for the thirst. So you don't have to even train animals or human being. We would be seeking out and drinking water just from the physiological response. But if you can't access water, either because like you have a stroke or you are unconscious and you are restrained, then you may develop hyponatremia. So again, normal renal response to hyponatremia is because osmolality is high, we want to dilute the blood, right? So we want to reclaim as much water as possible. So the urine will turn out to be low volume and very concentrated. So usually osmolality will be high and the low volume. On the other hand, if urine osmolality is also inappropriately high, that may be because there is osmotically active substances in the urine, which is dragging along the water. The commonest example is poorly controlled diabetes. Blood sugars are in the 700-800 milligram per deciliter, and if somebody has poorly controlled diabetes for a few days or week, because of the high blood glucose, urine will be loaded with glucose as well. There is glycosuria, and with glycosuria, water is dragged along. But when you go and measure the total osmol or the osmolality of the urine made, it will be high. Just a quick touch up on the causes of hyponatremia. It's either because your thirst mechanism is impaired, or you have true renal water loss, or non-renal water loss, such as like sweating, or sometimes it not because sodium, not because of water loss, but true sodium gain from administration of hypertonic saline or sodium bicarbonate. Impaired thirst mechanism is due to primary hypodipsia, people who have hypothalamus disorder, but more likely limited access to water in elderly demented patient, stroke patient, bedbound patient, or renal water loss will be. Classical example is diabetes insipidus, because the body lacks antidiuretic hormone, and because of that, ADH မရှိဘူး ADH မရှိတဲ့အတွက် you will develop polyuria a lot. The name, as the name implies, ADH, it acts by being antidiuretics. The diabetes insipidus can be either central or nephrogenic. Osmotic diuretics, we have talked about it, poorly controlled diabetes. So this is the quick algorithm for evaluating the hyponatremia. You look at the ECF volume. If the ECF volume is increased, generally it is due to net gain of sodium, such as like hypertonic saline, hypertonic sodium bicarbonate, too much sodium in TPN. But if the ECF volume is not increased, then we look at the urine, how the urine is appropriately responding. If urine is responding appropriately, which is very small volume and maximally concentrated, then the kidneys are not the problem. Kidneys are responding correctly, so it's become from insensible water loss, GI water loss, secondary hypodysphagia, those kind of situation where there is lack of water intake. On the other hand, if the kidneys are not responding appropriately, we go and measure the total urine solute. Total urine solute you can get by measuring how much urine you make in a 24-hour, multiplying that by random urine osmolality. Urine osmolality are say like 300 milligram per deciliter. If the urine output per day is 3 liters, so the total amount of osmol or urine solute excreted is 900. The cutoff is about 900. If urine solute is greater than 900 per day, that indicates that urine has unusual osmotically active substances, such as like diuretic, osmotic diuretics like a hyperglycemia. But if you don't have that, then you truly have diabetes insipidus, which can be central or nephrogenic. Central is true lack of ADH hormone, whereas nephrogenic is the kidney's resistance to ADH hormone, even though ADH is present. Quick run through on potassium disorders. Beware that the extracellular potassium represent only like a small 2% of total body potassium. The bulk of body potassium is in the cells. So what I'm trying to reiterate is that if you can shift the potassium inside and outside effectively, we can somewhat correct the hyperkalemia and hypokalemia. But the extracellular space မှာရှိတဲ့ potassium total เนาะ 5 liter blood volume မှာရှိတဲ့ဟာ 70 milli equivalent လောက်ပဲရှိတယ် total body မှာ intracellular the total body is about like 3,500 milli equivalent. So if you have hyperkalemia, if you can shift the potassium inside the cell, at least for a temporary basis, we can quickly and effectively bring down the potassium. And likewise, even with the slightest shift of potassium out of the cell, you can have significant hyperkalemia in the ECF. Normally, potassium balance intake and output is equal. There is no net gain or net loss, and potassium is maintained. On an average diet, the total daily intake of potassium is about 100 milli equivalent, and likewise, same amount get excreted, about 90% gets out of the kidneys, and about 10 milli equivalent will go out of the GI secretions. So which factors can regulate the potassium shift across the cell membranes? Insulin and catecholamines can do it, and acid-base status. Metabolic acidosis can shift potassium out of the cells, leading to hyperkalemia, and likewise, correcting the metabolic acidosis can shift the potassium back into the cells. I will not go much in detail about the site where the potassium reabsorbed. Just suffice to say that potassium normally is well reabsorbed, and the urine potassium secretion is under the control of aldosterone, which reabsorb potassium in exchange for sodium. And because of that, the higher the distal sodium delivery and higher the urine flow rate, there will be less reabsorption of potassium because too much sodium is delivered to there. So this is the distal convoluted tubule principal cell. This is the site of the mineralocorticoid action, which is the main regulator of potassium reabsorption. It reabsorbs through the sodium potassium exchange pump. The mineralocorticoid property are sodium will restore there, aldosterone, and that's how it restores the blood volume. That's how people develop hypertension when you have too much hyperaldosterone, too much sodium reabsorbed. But each time when the sodium is reabsorbed, it is accompanied by the similar amount of potassium molecule being excreted. So ဒါကြောင့်မလို့ hyperaldosteronism ရှိတဲ့လူတွေမှာ one of the common findings are moderate or mild hypokalemia is present, because as long as this pump is overactive, there will be net potassium excretion and the blood potassium will be low. Likewise, if you have hypoaldosteronism, there will be lack of potassium excretion, and there will be hyperkalemia. Hypokalemia, could be from low intake or could be from losses. The losses can be from GI losses, gastroenteritis, diarrhea, those kind of or it can be from sweat, or it can be from renal potassium loss. I will not go into details of those, or sometimes it may be because potassium enter the cellular space, intracellular space, such as like metabolic acidosis, sometimes treatment of megaloblastic anemia by B12 folate because of there is increased synthesis of cells and usage of potassium into the cells. But if you have hypertension with hypokalemia, that combination usually suggests that mineralocorticoids are in action. That's the only condition where you have hypokalemia, but with hypertension. So it can be primary hyperaldosteronism, high renin state, glucocorticoid removal, hypertension, and all these rare syndrome, which I will not go into detail, that probably is not going to be useful in day-to-day clinical practice. This is more like, for nephrology fellow thing. So hypokalemia, we quickly checked out whether this is redistribution, think of those conditions and correct those. And then we quickly measure the urine potassium to determine whether the loss is through the kidneys or extrarenal. If 24-hour urine potassium is high, that indicate renal loss. Another way to look at it is calculating the transtubular potassium gradient, which I'll go over a little bit. But if the urine potassium, 24 urine potassium is not too high, that indicate more of extrarenal loss. In that case, you look at the bicarbonate, plasma bicarbonate. If you have acidosis, low bicarb, diarrhea, biliary losses like a pancreatic juice losses, where you have high bicarbonate, it is due to prior diuretics, volume contraction, prior vomiting, chronic laxatives. But if the potassium loss is confirmed to be from the kidney, we look at whether patient has hypertension or not. If the patient is hypertension, we start to think of more of endocrine causes. We check the renin level. If the renin level is low, it is due to hyperaldosterone state, and we go and measure the aldosterone. If the aldosterone is high, that's hyperaldosteronism. But aldosterone renin low aldosterone these rare endocrine, such as like syndrome of apparent mineralocorticoid excess or Cushing syndrome. Renin level high ဖြစ်တဲ့ဆိုလို့ရှိရင် aldosterone high ဖြစ်ရခြင်းကဒီ renin ကစပြီး high ဖြစ်လို့ဖြစ်တာ in that case these are the condition malignant hypertension, renal vascular disease, renal secreting tumor. If the patient doesn't have high blood pressure, then we look at the bicarbonate. If the bicarbonate is low, which is acidosis, then it is usually due to renal tubular acidosis. Normal bicarb, usually due to polyuria from acute tubular necrosis and recovery. But the bicarbonate is high, then we look at the urine chloride. If the urine chloride is low, this is due to vomiting. Whereas if the urine chloride is concomitantly high, it will be these endocrine syndromes. Hyperkalemia, again, we can think of it in the same mechanism. It's either because increased intake or reduced renal excretion. Reduced renal excretion because you have renal failure, because you have aldosterone deficiency, like I showed you earlier, aldosterone excrete the potassium by increasing the sodium reabsorption, or drugs that interfere the renal angiotensin aldosterone system, such as like ACE inhibitors, renal insufficiency, distal tubular defects, because there is impaired secretion selectively in the potassium, or sometimes due to excess dietary intake. And this is only relevant if someone has renal failure. If you have normal renal function, it is very rare or unlikely to develop hyperkalemia just from dietary intake. Sometimes it may be shift from intracellular to extracellular space, such as cell necrosis, severe metabolic acidosis, severe exercise, succinylcholine toxicity, or malignant hyperthermia, or because there is impaired entry to ICF, such as beta blockers, insulin deficiency, and rare genetic syndromes like hyperkalemic periodic paralysis. Drug-induced hyperkalemia, these are the drugs that can cause hyperkalemia by different mechanisms. I will not go in detail because I want to talk to a little bit about the management. Here are some of the food that are rich in potassium. As you commonly know, bananas, pinto beans, raisins, honeydew, because in West you use honeydew, but in Burma it will be more like a berry, watermelon, collard greens, the maro, the African American yansar, collard green through tomato, orange, milk, potato chips, those are rich in potassium. Now there is one formula called transtubular potassium gradient. As the name implies, it is calculating the gradient of the potassium between the renal tubular cells, between the cell inside and the tubular lumen. The tubular lumen there the potassium cell there potassium concentration and tubular lumenia gradient. It's called transtubular potassium gradient, across the cell potassium gradient. And that concept can be used both in hypo and hyperkalemia. Normal transtubular potassium gradient is about 2 to 4, and the utility of 4 to 6. The utility of transtubular potassium gradient is differentiating whether hypo or hyperkalemia is the renal problem in origin or not. Kidney problem dietary problem differentiate low. Okay, for example, like normal TTKG is 4 to 6. In case of hypokalemia, normally in a normal kidney, the expected response is the gradient become less, so that not much potassium will be excreted because the body should be reclaiming and trying to preserve the potassium. So transtubular potassium gradient should become lower than normal in hypokalemia. If it is inappropriately high, that means the renal loss. If transtubular potassium gradient is low as expected, then hypokalemia is non-renal in origin and from the renal loss. Likewise, in hyperkalemia, the appropriate response is the gradient has to become high. The gradient should become steep so that there will be net excretion of potassium into the tubular lumen to excrete. So if we have high transtubular potassium gradient, that's not the renal problem. Renal or the kidney is responding as it should be, so it is probably due to dietary intake or other conditions. Whereas in spite of the hyperkalemia, TTKG is not rising up to or higher than 8, then it indicates that the kidneys are the trouble spot. Kidneys are not excreting. So transtubular potassium gradient can be used both in hypo and hyperkalemia. It is useful in differentiating whether the underlying pathology is kidney versus extrarenal. To calculate transtubular potassium gradient, you have to order random urine potassium, random serum osmolality, urine osmolality, and serum potassium. Serum potassium is widely available from electrolyte panel already, but these three you have to order specifically. So hyperkalemia, why do you care about hyperkalemia? As everyone knows, uncorrected and severe hyperkalemia will lead to cardiac arrhythmia and lead to cardiac arrest. There are two scenarios where hyperkalemia is faced. In an inpatient setting, ICU patients who are acutely sick, usually, not always, but usually in those scenarios, the reason is due to acute renal failure, acute kidney injury, or due to cellular shift. For example, on the other hand, if you have office hyperkalemia, patient is not critically sick, patient is walking, talking, but you find that patient has hyperkalemia, it is not due to renal failure, usually due to reduced mineralocorticoid activity and other collecting duct abnormalities such as drugs, tubulointerstitial nephritis, and urine obstruction, and those like that. So in acute management of hyperkalemia, the goal is, especially in the hospital setting, the goal is to prevent cardiac arrhythmia as soon as you can. Ultimately, we would like to bring down the potassium based on what's the underlying condition, but the first goal is to quickly correct it, and correcting it also means that to stabilize the cardiac membrane from being hyperexcitable. So what we have to do is do an EKG. If the EKG changes are present, it becomes even more urgent to act on it. The EKG changes, as you all know, would include peak T wave, flat P wave, YQRS. Those suggest that cardiac arrhythmias can be imminent. So in that case, what you would do is to stabilize the myocardium by giving IV calcium and try to shift the potassium into the intracellular space, which works better than trying to excrete the potassium. So you want to give insulin, but if you give insulin without concomitant IV dextrose, you will be giving hypoglycemia to the patient. So you have to give both 50% dextrose together with regular insulin. And then you correct the acidosis by giving 1 or 2 ampulla of sodium bicarbonate, which will drive the potassium into the cell, right? pH, acid-base status determine the cellular shift. And after that, we can give potassium exchange resin orally. Beware that those will take a good 2 to 6 hours before the effect kicks in. So this would not be the first line treatment. These above 3 are the first line treatment. You can give potassium exchange resin, Kxalate, which trap the potassium in the gut and excrete it through the stool. If the patient is unconscious, we can give it rectally. Here are some of the newer potassium binding resins, sodium, zirconium, cyclosalate, or patriometer. The advantage over Kxalate is it is less GI irritant. You don't get too much GI irritation with these newer potassium binding resins. And of course, hemodialysis, much more effective. But of course, hemodialysis may not be available everywhere or right away. You need to put in a dialysis catheter and all those things. So, all right. That ends my lecture today. So let's quickly go back to the earlier questions that we had answered. And then after that, we will open the floor for the questions. Okay. So this is the question number 1. We had it earlier. 20-year-old female evaluated for seizures. So there is what indicates that there is neurological impairment. So rapid treatment is probably necessary. 20-year-old supposedly previously healthy, and the friend informed that patient took this ecstasy. Usually in West, those are used in the dance club or the rave party. People, do not get. People have high energy and they can dance to the music for hours. But the downside is it can lead to these known complications. So patient is young, supposedly previously healthy, had taken ecstasy, presented with seizure, no localizing neurological finding. The remainder of the physical exam is unremarkable. It doesn't look like volume depleted or dehydrated or hypoadrenalism or Addison disease and things like that. So the main abnormality is serum sodium 118 with neurological symptoms. So your treatment is, which will be the treatment? Only one question is correct. 3% hypertonic saline infusion is the correct answer to rapidly correct it. In this patient, the hyponatremia is abrupt, most likely within a couple of hours, definitely shorter than 48 hours. So you should not need to worry about rapid correction of hyponatremia leading to centrum pontine myelinosis. So that's why, and patient has neurological symptoms, so you have to correct it quickly, and it is safe to do so. You got a good history that this is acute hyponatremia, so 3% hypertonic saline infusion is the correct answer. Water restriction is more for chronic hyponatremia from SIADH. It will take 4 or 5 days to kick in and not applicable. IV conivaptan is the newer ADH receptor blockers. Again, in this patient, even this IV conivaptan, which will take about 4 to 6 hours, is not quick enough. And the other thing is that you cannot predict or gauge how quickly sodium will be corrected. Hypertonic saline, we have mathematical formulas, how many cc per hour. By giving certain number of hypertonic saline, by adjusting the rate, we can titrate how quickly we can correct the sodium. With the IV conivaptan, sometimes sodium may overshoot, sometimes it may not. so it is not reliable. IV desmopressin is used in hypernatremia in SIADH, diabetes insipidus, when you have lack of ADH. IV furosemide can be used in treatment of SIADH. Again, it will not quickly correct the sodium. So the key is development of hyponatremia seems to be acute. Patient is having neurological symptoms, then you should act and treat quickly as well. And the best to treat it is hypertonic saline. Okay. And number two, 63-year-old female is known with type 2 diabetes and hypertension. It takes glipizide, anti-diabetic medicine, and lisinopril/hydrochlorothiazide for hypertension, ACE inhibitor. And she came down with COVID-19 pneumonia. She had been sick for about a week. Febrile, what indicates is that she probably have sweating and extrarenal fluid loss for the past 3-4 days. Similarly, oral intake is poor, become weak. Situation is not too bad. She's being treated at home by the visiting physician who drew the labs and showing potassium of 6.8 and slightly acidotic, BUN of 7.4 and creatinine 1.9. So if people who attended yesterday's lecture, you can see that BUN is disproportionately higher than creatinine. If it is due to true renal failure, for creatinine of 2, you would expect BUN to be like about 30, 40, but BUN is disproportionately higher. That's a clue that likely to be more of, there is significant component of volume depletion or dehydration rather than all from renal failure. Anyway, no hemolysis is reported, just to clear that, because incorrect sampling or hemolyzed sample can lead to artificial hyperkalemia. So potassium is 6.8. Look like little volume depleted. What would you treat? So this is multiple choice. Your next action include get an urgent ECG. That is correct. At any hyperkalemia, if you have concomitant ECG changes, that indicate you should even be acting more quickly, and this is imminent cardiac arrhythmia. Give oral sodium polystyrene sulfonate Kexalate 30 grams. In general, it can be true, but what the examiner is trying to find out is what are the immediate measures you'll be doing, your next action. What I'm trying to say is that if you delay giving Kexalate by 1 hour, it doesn't matter in the big picture because it's going to take about 6 hours to kick in. So that should not be the first action you need to do. You can do other things first. Yes, eventually we may give it, but delaying giving Kexalate by half an hour is not going to make a big impact on the outcome. Call ambulance and sending to a hospital that can perform dialysis. This patient may or may not need dialysis. The encouraging thing is that patient looks like volume depleted pattern. So if that is the case, if you give fluid resuscitation, there's a good possibility BUN creatinine will improve and patient may not need dialysis. So the key is to recheck it a couple of hours later. We will not jump in, even if this patient is an inpatient in the West, which has 24/7 dialysis capability. I would not put the patient on dialysis in the scenario right away. We will do other things first. Give 50 grams of IV sodium bicarbonate. That is correct. By changing the acid-base status, by correcting the acidosis, you can shift potassium into the cells, and that will reduce the extracellular potassium. Give 4 grams of PO albuterol. Theoretically, that can be true. Beta agonists can stimulate entry of potassium into the cell, but the effect is very, very mild. PO will take a while, and this patient seemed to be already tachypneic from pneumonia. Patient has okay, so it doesn't indicate tachypnea, but the point is that patient has pneumonia, patient has pulmonary issue, and the efficacy is very, very low. The time it takes is low, so you can assume that we almost never use beta agonist as a treatment for hyperkalemia anymore. Give 10 cc of IV calcium gluconate, yes, it's not to bring down the potassium, but it's to stabilize the myocardium so that arrhythmias do not take place. Number 7, give 50 cc of dextrose with 10 unit of regular insulin IV. The key is we want to give insulin to drive potassium into the cell, but to prevent inadvertent iatrogenic hypoglycemia, you have to give dextrose as well. So the correct answers are number 1, 4, 6, and 7. So that concludes my lecture today, and I'll be happy to take the questions from the audience, if any. Outpatient setting မှာရောဒီလိုမျိုးတို့ COVID နဲ့ acutely ill ဖြစ်တဲ့လူနာတွေ hyperkalemia ဟိုပေါ့ electrolyte measure လုပ်ဖို့အဆင်ပြေမပြေတော့မသိဘူးပေါ့နော် but I hope this knowledge is useful in case if you come across hyperkalemic patients as outpatient.
Thank you ပါအဆင်ပြေပါတယ်
Okay, you're welcome. မနေ့က topic ကဟာကိုပြန်မေးချင်သေးတယ် acute kidney injury, acute renal failure ကိုထပ်မေးချင်တယ်ဆိုလဲ There is one question in the chat box. What is the action of furosemide giving alternate day in heart disease? Heart disease ဆိုတာဘာကိုဆိုလိုချင်တာလဲ congestive heart failure လား coronary artery disease လား cardiac arrhythmia I'm assuming you meant congestive heart failure เนาะဘာလို့လဲဆိုတော့ diuretics ကို coronary artery disease တို့ arrhythmia တို့မှာတော့ပေးမယ်လို့စိတ်ကူးမရှိဘူး it all depends on the degree of CHF status. I don't see any reason why it should be giving alternate day. Only reason is patient edema is not too bad. Patient's volume status, hypervolemia is not too bad. And that's why just like any medication, you reduce the dose, but otherwise there should not be any reason why it has to specifically give alternate day. If any, you should be giving daily, and to get effective diuresis, furosemide being a shorter acting medicine, preferably it should be giving twice a day. But of course, depending on how high a dose you need. I don't see why it is giving alternate day, except you don't need that much, you know, edema I think solo ဒါကြောင့်ပဲဖြစ်ပါလိမ့်မယ် Hopefully you now remember how to use diuretic correctly. Second MB, third MB information just refreshing. The next question come up is, may I know the role of nebulized salbutamol in non-tachypneic patient with treatment of hyperkalemia? Yes, you can give it, especially if the patient is not tachypneic, especially if it is nebulized salbutamol. Yes, it will be quicker acting than oral. So yes, I would say you can use it, but my experience is compared to other measures, the extent of correction is very low. So if patient is not tachypneic, dyspneic, yeah, sure. You know, if you have nothing else, there is no harm in using it. But compared to other things like sodium bicarbonate trying to shift the potassium, glucose insulin, the beta agonist like salbutamol, the magnitude of correction is very low. That's the only reason, but you can give it. One question come up. Is it safe to give calcium gluconate over 1 minute? The short answer is yes, but usually we give it in a small IV infusion bag, like 100 cc of normal saline, and we give it in about 5 to 10 minutes time. But yes, we can give it in 1 minute time. Not a problem. Yeah. အခုခေတ်တော့မသိဘူးဆရာတို့လွန်ခဲ့တဲ့နှစ်30တုန်းက GP လုပ်တုန်းကဆိုလို့ရှိရင် GP မှာ IV calcium about 10 cc လောက်ပေးတဲ့အလေးထား quite common လေခုတော့မပြောတတ်ဘူး
ဟုတ်ဆရာတို့ဆရာမတို့မေးခွန်းလေးရှင်မေးလို့ရပါတယ်ခင်ဗျဟုတ်ကဲ့ပါဆရာ PowerPoint ကလေဆရာဟုတ်ကဲ့ဆရာမေးမလို့လားမသိဘူးခင်ဗျဗီဒီယိုလေးတက်လာတွေ့လို့ပါဟုတ်မေးလို့ရပါတယ်ဆရာဟုတ်ကဲ့ပါဟုတ် PowerPoint လေးဆရာကျွန်တော်မနေ့က share ပေးထားတာကိုပဲကျွန်တော် upload လုပ်ရင်အဆင်ပြေမယ်ထင်တယ်เนาะဆရာ day 2 အတွက်က
ဟုတ်ပါတယ်
ဟုတ်ကဲ့ဟုတ်ကျေးဇူးပါဆရာဟုတ်ကဲ့ပါဆရာ
ဟိုအားလုံးပါပါတယ်တခုပဲမပါတာဒီဟိုပေါ့ poll question လေးတွေအဲ့တုန်းကမထည့်ထားသေးလို့ poll question ကို separately ပို့လိုက်တာ otherwise every other slide is the same. So if you just want to post the lecture, yeah, that's good enough.
ဟုတ်ကဲ့ဆရာကျေးဇူးပါဆရာဟုတ်ကဲ့မရှိကြတော့ဘူးနဲ့တူပါတယ်ဟုတ်ကျေးဇူးအများကြီးတင်ပါတယ်ဆရာဟုတ်ကဲ့ခင်ဗျာဟုတ်
Okay, thank you everyone. All the best of luck. Hope you know.
ဟုတ်ဆရာဟုတ်
know.
ဟုတ်ကဲ့ပါ
Alright.
ဆရာဟုတ်ဆရာမအားတဲ့ကြားရနေပြီးတော့ trainer ဖြစ်နေပါပြီလားဟုတ်ကျေးဇူးအများကြီးတင်ပါတယ်ဆရာဟုတ်ကဲ့ပါ
Okay, no. Bye.